So welcome everybody. We're going to be talking today about navigating the health insurance landscape. Kyle and I were just talking about how this topic is more important than ever right now because, first of all, it's a timely topic as open enrollment season is coming up, but also, we have a really competitive market where I think most companies, if not all companies, are looking to attract and retain the best people. And it's just really important to curate a robust employee benefits package. So we're going to go over a lot of that stuff today. As always, if you have questions during anytime during the presentation, put them in the Q&A box at the bottom of your screen, and we'll get to as many as we can. I'll talk about the HR manuals a little bit later on if we have time. As most of you know, HR Simple provides easy to understand state-specific solutions for HR professionals to stay on top of changing labor laws through digital and print guides and these monthly webinars. We do about one a month, but lately we've been doing two, and I think that we're going to continue to do that because there's just so much to talk about. So let me introduce Kyle, our presenter today. Kyle is one of the partners at EP6, which is a carrier and enrollment platform firm that specializes in employee benefits education, communication, and benefits implementation. Kyle has worked with some of the largest health systems in the United States as a billing specialist for Epic Systems and as an independent insurance agent before taking on his role with EP6. And with that, I'm going to hand it off to you, Kyle, and I will be back for the Q&A.
Excellent. Thanks so much, Amy. Good afternoon, everybody. I'm excited to be with you. Again, my name is Kyle Welton. I'm one of the partners at EP6. And so this training that I'm going to be taking you through, at least a portion of it, was originally designed for the benefit counselors that work with our clients. So EP6 focuses on the education of benefits for employees, along with a focus on supporting technology. So really the goal for today's training is to help you understand the different types of health insurance networks, different key concepts in medical benefits, some regulatory pieces here, because as you're navigating through benefit offerings for your employees or different solutions, having just a baseline understanding of where these are, these concepts, how all these things came into being is helpful as you're looking at what's going to be the best fit for you and your employees. So when we're thinking about health plans, what we'll be talking really through here to start is the four major types of health networks and how those are structured, and kind of the philosophy behind that. And then from that, we're going to build out into other trends that have emerged in with health benefits and some key pieces to understand. And a trend that you're going to hear repeatedly throughout this training is that as healthcare costs have risen and the regulatory environment got more complex, plan designs and other things have changed in a way to help accommodate and lower overall premium costs in with health insurance. So that's where a lot of what we see in our today's current healthcare marketplace, why it looks and functions the way it does. So the first group that we're going to take a look at here is the health maintenance organization, so HMOs. So if you can think of this on a spectrum, right, and I'll have a table for you in this as well. HMOs are going to be on the most restrictive and least expensive in general. And then PPOs on the other end of that, we'll get to them next, are going to be the most open in terms of their benefit provisions, but also more expensive. So with HMOs, these are organizations that actually both provide health services and health insurance. So that's one of the key pieces to an HMO is that they actually own the facilities that are providing the members care, and then members are paying them for the insurance and access to those organizations. HMOs emerged in the kind of mid-'80s as a way to help both control healthcare costs, but provide a coordinated member experience as part of that enrollment. So some key pieces as well to HMOs to understand is that one requirement is that all members are going to have a primary care provider who really acts as the quarterback of the care, if you will, for a more folksy analogy, but they're the care coordinator for that patient. So in order for somebody to go see a specialist or to get certain care or things like that, everything has to start with the primary care provider. The term that's utilized in insurance for this is a gated plan, because there is a gatekeeper on access to care, which is the primary care provider. So, and this is really where a lot of that cost savings come into place. It's the combination of, you're going to use organizations that we own, facilities that we own, and then you're also going to have to go see a primary care provider in order to go see a specialist or get care in a hospital, right? That's going to be far more expensive. So the first cost savings that come into this is overhead. So there's a significant amount of back-end infrastructure that goes in for hospitals and clinics to get reimbursed by health insurance companies. And so this used to be the world that I lived in as an implementation specialist with Epic. My job was actually setting up the software, building out the contracts and the coding and all of that actually got these organizations reimbursed. There's a significant amount of people, time, and infrastructure investment, all of that going in just to get paid, right, through the billing system. HMOs are cutting out that middleman because they're billing themselves essentially, right? They're still going to have some billing department for some HMO facilities will accept outside insurances these days, but really most of that's all coming in through members that are members of the HMO. The other part to this as well is that the primary care provider is now filtering care and providing treatment that can be done in an ambulatory setting. When I refer to ambulatory, I'm talking about clinics that you can walk in and out of. It's where the term comes from. So that ambulatory setting is significantly less expensive in terms of providing care and services than a hospital setting. And so the primary care providers that are going through and doing all of this work really are helping to make sure that the member is getting provided the care that they actually need, versus somebody says, well, there's something wrong with this part of me, I should immediately go to see the specialist, rather than their primary care provider who's got full access of their health history, can do some additional troubleshooting and review with the member. HMOs offer a coordinated care experience at a lower cost, right? However, members are more restricted in how they receive care. The other thing to think about with this is that HMOs typically have a requirement that members live and or work in their geographic service area. And that's simply because, right, unless you're a Kaiser Permanente, which is all over California and many other states, most HMOs are limited to a certain geographic region, and they want to make sure that members have access to care. Now, many HMOs these days will have a option for employers that have employees that live outside of that, multi-state. That's a point of service plan. We'll look at that type here in just a second. But one thing that's important to understand for everybody on all of these plans is that emergency care is always covered. So in 1986, Congress passed a law that said it is illegal to deny somebody emergency care if they're uninsured or don't have an insurance that's accepted by your facility. So if it's truly emergency care, they are going to have coverage. And also by law, their insurance has to cover it at the same cost share as they would in network in that situation. So, or at least has to provide coverage for it, depending on what the provisions are. So the number one barrier to folks participating in an HMO is really as often as that fear of, well, what if I go out of state and something happens and now I don't have access to emergency care, I'm gonna be bankrupt. They'll be transferred to a facility that can provide care once the emergency period is ended. But that is, there is a law in place, federal law, that requires them to receive care. So that's not going to hurt you or your employees if you choose that an HMO style network is the best route. So now let's move to that other end of the spectrum, PPO, preferred provider organizations. So under a PPO, there is no requirement to establish a primary care provider. It's open within both the network of preferred providers, as well as the out-of-network providers. You can still go see them without a referral in order to have coverage for it. Your cost sharing will differ. We'll touch on that in just a second. But it's not going to have to go through a primary care provider in order to be able to see that person. Okay, it's not a gated plan unless it's a specifically designed provision inside of it. That network of preferred providers, essentially what's happened here is that network has a negotiated reimbursement cost with the insurance company for the network. So the providers are all, in hospital organizations, price out their services by, the term is CPT code. So each individual code has those pieces and with a certain charge that is tied to it, right? Now, they're going to negotiate with a insurance company who's going to say, you charge this much, we're willing to reimburse you this much. And when they come to an agreement, they now have a negotiated fee schedule. So even though the amount that's billed for the employee, what's actually being reimbursed is lower because that's the negotiated cost between the insurance company and the healthcare organization. So the providers want to do this because it's providing them a pipeline of business, right? There's people who are in network who are going to go see these providers. And that's really where kind of that incentive structure comes in. The other part of this is that the PPO organization is going to incentivize in-network care, making that usage more attractive for the providers who participate, because now the deductible, out-of-pocket maximum copays have been doubled, right, as a result of going to seek out-of-network care. So you may be able to get that reimbursed, but your $4,000 deductible has now become $8,000, right? Or your coinsurance has gone from 20% to 40%. So that's all driving the member to utilize the preferred providers so that they have a cost share that's as low as possible. You may have some PPOs that have a narrow network to help control cost and lower premium. That would be, again, if there's less exposure, less providers to manage, things like that, there's less overall cost in the insurance plan administration. So that can help lower that overall cost. But if they're seeing somebody out of network, even if they're in the same town, right, it's a narrow network, it is going to increase that out-of-pocket cost share. So now we've looked at the two kind of ends of the spectrum here. Really, the next group we want to take a look at are point of service plans. So in a POS plans, you can think of this a bit like a hybrid of an HMO and a PPO. So like an HMO, members have to establish a primary care provider to see a specialist. However, like a PPO, they have coverage for providers out of network, right? So really, you get the coordinated care experience of an HMO without the restrictions just to go to providers and network. So a POS plan is going to offer more flexibility, right, in terms of allowing people to see someone out of network, but they still have to go through that primary care provider to get access to see a specialist. Similar to in PPO, that out-of-network care is covered, but you're going to double the cost exposure, the cost share to the member, so that the in-network providers are getting more of that business. An EPO functions closer to an HMO, but it's still a bit of a blend, if you will, between an HMO and a PPO. So like an HMO, EPOs do not offer coverage out of network. So a PPO is a preferred provider organization, preferred meaning you can see somebody even if they're not preferred, right? EPO is an exclusive provider organization, meaning if they are not in network, they are excluded. They do not have access to that person. So they don't have to establish a primary care provider in order to seek care, but they do have to go see somebody in network. So if you think about this in terms of a kind of a grid here, right? Your network design, when we're talking about your HMOs, right, they're going to be the lowest cost, and your EPO is going to be more expensive than an HMO, less expensive than a point of service plan. POS is going to be the next level, a little more expensive. It's less expensive than a PPO. It's more expensive than an HMO or an EPO, and then PPO is typically the most expensive. Now, these are not universals here. There's always some specifics that can come in with plan design, but typically these are how these things shake out within these types of health plans. So I now want to take a look at high deductible health plans, because this is a big consideration and a kind of growing topic in benefits. So high deductible health plans emerged in the early 2000s as another way to help control rising cost of healthcare and lower premium. So really the theory behind this is creating more of what's referred to as a consumer-driven model of healthcare, where previously, right, there weren't as many cost shares. It was a little more simple. It's all co-pays. Maybe not even have a deductible, and you've got a card, exactly what you need. You go to see somebody in network, right? Again, as healthcare became more expensive, the regulatory environment grew more complex. Plan designs changed to limit exposure as a way to help control cost, and which means that people have to be better consumers of their healthcare. The idea behind a qualified high deductible health plan, I should note that, and I believe it's on the next slide, having a high deductible does not make something a HDHP, right? A high deductible health plan is a specific term that the IRS uses, and when you are enrolled in a qualified high deductible health plan, there is no first dollar coverage outside of preventative care. So what that means is that all of the cost exposure is front loaded onto the member. So if you got a $4,000 deductible, unless it's a preventative care as defined by the ACA, you're going to pay for that entire cost until you reach that $4,000 deductible, and then co-insurance or co-pays are going to kick in. Right. The idea behind this is that if a member has to think about, okay, I'm going in for this, it's not preventative, right? Or I'm not, or XYZ, what is this going to cost me? It's going to make them more cautious in the care that they seek, so that it filters out what people refer to as unnecessary care, or so on and so forth. That could have been addressed, or reduce unnecessary visits to urgent care or the emergency room, so on and so forth. So that front-loaded exposure is what allows these premiums to be so much lower on these plans, because there's a lot more that has to happen and come out of the member's pocket before the insurance company is going to pay a dime to any provider, right? Some employers may offer an HSA or an HRA as a way to help reduce these costs. Remember, HSA is a savings account that's fully vested. Once that money is provided to the employee in the HSA, it is theirs. HRAs are a reimbursement arrangement between the employer and the employee for a specifically for a set of services. So you can be more limited in what is reimbursed on an HRA. HSA really is on the employee who owns the HSA dollars to make sure they're only spent on qualified health expenses, or they will incur a tax penalty. So as I mentioned before, having a high deductible does not make a plan a high deductible health plan. And honestly, when you look at the annual contributions that are allowed, the deductible rules, these are for 2022. I believe yesterday the IRS just announced the 2023 months. I haven't had a chance to update this yet. But for 2022, you have to have at least $1,400 for an individual coverage or $2,800 for family to qualify as a high deductible. The max, those go up to $7,050, as long as that's also the out-of-pocket maximum on the plan. So there's that $1,400 for individual coverage, $2,800 for family. The out-of-pocket max cannot exceed $7,050 or $1,410 for a family. High deductible health plans can have any kind of network structure. They do not have to be, they could be an HMO, they could be a PPO, POS, or EPO. That's not restricted based on the network type. It has to do with the way the deductible functions. And the other thing that's important to understand about the way that high deductible health plans work is that front-loaded exposure, the employee cost or member cost, right, in that deductible, is going to be the negotiated rate between the insurance company and the provider. It is not the raw cost of services. So the best way I can explain this is if you get an explanation of benefits in EOB, it's going to show you the allowed amount, which is the negotiated reimbursement, and then and then a non-allowed amount, right? So that's the amount that's been written off. The member is only responsible for the allowed amount because they are a member. It is covered under the plan. However, the plan doesn't pay until the employee has met their cost share responsibilities. Okay, so that's an important thing to understand. The other thing that's a big barrier to high deductible health plans participation is people think they have to pay for a physical. I just want to stress the Affordable Care Act mandates by law, if it is a qualified coverage, members cannot be billed for cost share on preventative services. Those preventative services are defined by law. It does require folks to be a little more careful about when they go in for a physical, because if they go for a screening that's not considered preventative, it's diagnostic in nature, their physical will be covered, but they will get a bill for that part of the care that was not diagnostic. And that is, or not preventative, excuse me, it's coded as diagnostic. So that's just a key education point. So let's now take a look at self-funded and level funded plan. So something that many Americans are not aware of is that employers can actually act as their own health insurance company, if you will, for their employees. Most employers are going to utilize, I shouldn't say most, many employers, I'd say the majority, are using a fully insured product. So what that means is that all the risk is assumed by the insurance company and all the premium is paid to the insurance company. Claims are paid by the insurance company. They're the ones doing the network, doing the negotiation. Everything is outsourced to them, right? As a result, your plan designs are more limited because it's a fully insured product and the health insurance carrier is going to design that. And rate is determined based on the group's evaluated risk, right? Now we get into level funded and self-funded. So level funded is kind of the middle part here, and it's sometimes referred to as partially self-funded. A lot of times these plans tend to be more popular with smaller employers. And when I say smaller employers, you know, those under 50 but even those in 50 to 100 employees, but particularly those that are in the true small group rating where they're getting into age banded, community rated rates. In these situations, the risk is split between the employer and the carrier. The employer pays a set or a level amount each month to the carrier to cover expected claims, stop loss, and admin costs. It is possible on some level funded plans, not all, it just depends on the arrangement, that there would be a reimbursement if claims are low that year, right? It was overfunded. Others put that back into the general health fund. But there's if claims run high, there is going to be an increase in cost on those plans. Employer design is still a little more limited on level funded plans than a true self-funded plan. And then you get to self-funded where all the risk is assumed by the employer. They're contracting a third-party administrator who is then providing them access to a network, paying the claims, getting the cards, so on and so forth. And the employer is now taking those premium contributions from the employee and putting that into an insured fund. Now they can use those dollars to pay for the stop loss coverage, right? So the employer is going to have a stop loss policy. So if somebody gets into truly catastrophic situation, is in the hospital every day and is in a coma, right, for an extended period of time, and there's millions of dollars of health insurance claims, that's all going to go to the stop loss carrier, so that's not fully absorbed by the employer. But the other parts are going to get sent to that health fund. Any savings are retained by the employer. Now, most will roll that over in the health fund for future years, anticipating that claims will fluctuate, right? But it just depends on the group. This is very, very common in large employers and public employers to have a self-funded medical plan. The other thing to note is that employers have more flexibility in designing self-funded plans because it's a self-funded product and they don't have the same level of regulatory restrictions on it that fully insured products do. One of the trends that emerged as a result, as part of self-funding, is reference-based pricing. So I'm not going to spend a ton of time on this, but I do want to introduce you to the concept. So again, as medical costs continue to rise and costs continue to increase for employees and employers, one new method that came about in 2011 is reference-based pricing. So what the idea behind this, and this only applies to self-funded plans and fully insured products do not do reference-based pricing. But the idea behind this is to, one, control costs, but also create more transparency. So if a provider or a hospital system accepts Medicare and Medicaid, which, believe it or not, providers do have a choice. In the United States, they do not have to, but if they do, what they're doing is they're accepting assignment. So they are accepting patients that are covered by Medicare or Medicaid, which means they cannot negotiate any of the fees that are paid to them as a result of the services provided. The federal government sets the reimbursement schedule that is published. It is public knowledge, and that is available to everybody. So Medicare and Medicaid reimbursed lower than any private health insurance product and any reference-based self-funded plan. The volume still makes them the single largest source of revenue for health providers in the US, just because the vast majority of consumers of healthcare are over the age of 65 and covered on Medicare, Medicaid. But again, they cannot do anything about what they are reimbursed. That is set by the federal government. It can't be negotiated. So what reference-based pricing does is it says, we're going to look at the fee schedule that's provided by CMS, the Center for Medicare Services, and say, we will reimburse you on a percentage of Medicare. So if Medicare pays you, this amount, we'll pay you 150% of that. But we're not going to pay you what they refer to this as the BUCAs of the world. So Blue Cross, United, Cigna, and Anthem, what the BUCAs will. And in some parts of the country, those reimbursement models are pretty high, where they're getting close to 1,000% of Medicare, meaning they're getting paid 10 times more than Medicare reimburses for that specific service. If you're on a self-funded plan and you're utilizing one of those network models, you're paying that negotiated cost, which means you have a much higher cost for care. In reference-based pricing models, they're going and negotiating with the provider and saying, we'll pay you a percentage increase of Medicare. You accept assignment, you accept this. If somebody with Medicare comes in, our client self-funded, we're not paying you less than Medicare, we're paying you more, but we're not paying what you get charged by some of these PPOs or other network providers or other network carriers. So at that point, the provider can choose to either say, okay, that reimbursement is fair, I will accept that. They can say, we want to negotiate this and we can do an alliance contract, which is always the ideal. An alliance contract creates a fee schedule that's accepted for that provider and all members of that self-funded plan. So essentially, they're in network, if you will. Or they can negotiate a single case agreement and say, I'm not willing to accept this as a full fee schedule, but I will accept this for this one particular patient on this single case. The other option is they can say, I'll take the money you're giving me, but I'm sending the balance, that balance bill, to the member. And so this is where most of the frustration comes in around reference-based pricing and why education is so important for members, is that balance billing will occur from time to time. Better TPAs have more alliance contracts, and so it's much lower where that occurs, but it is a reality, right? That's where the TPA, the concierge, is going to get involved when that balance bill comes in to negotiate on the member's behalf so you can get to a single case agreement or alliance contract. But most reference-based pricing plans are going to encourage the member to reach out to a concierge line or an app or something that's going to direct them to a provider that's going to accept reimbursement that's been negotiated so that the co-pays that they see on their card are exactly, or deductible is exactly what they owe, versus I paid my deductible and my co-insurance and the provider is still telling me that I owe more money, right? So now that we've talked about, network types, high deductible health plans, self-funded plans, I want to talk now about deductible and out-of-pocket max structures, because this can be a confusing concept, but it's important to understand for employees and how your plan is structured. So there are two different types of structures for a deductible and a out-of-pocket maximum. There is an embedded structure and there's a non-embedded structure. An embedded structure means that there is an individual deductible embedded inside the overall deductible. Essentially, think of this like stop loss insurance. What this means is that if one person on a family coverage gets into a serious incident, health insurance is going to kick in faster for that member because there's an individual deductible than the overall family plan, right? And I've got examples on the next slides because I know this can be tough to see without a visual. In a non-embedded structure, there is no individual deductible embedded. It's not like a stop loss. Whatever that number is what everybody, whether one or all on that plan, must satisfy in order to have co-insurance or other things kick in on the plan. So let's look at an example where an employee, John, has his wife and 2 kids covered on their medical insurance. They've got a $2,000 deductible for a single, $4,000 for a family. So John's deductible is $4,000 for the family. His out-of-pocket max is $4,000, $8,000. John's son has appendicitis, and the total cost for surgery and recovery comes out to $8,000. In this scenario, John's going to pay $3,200 for that care in an embedded structure, because the individual deductible of $2,000 is embedded inside that $4,000 family deductible. Then there's $1,200 in coinsurance because that remaining $6,000 is going to be subject to coinsurance. So the plan pays 80%, John pays 20%. Then his son has no deductible for the rest of the year. Let's say he breaks his arm later in the year. He's going to go right to coinsurance because his deductible has already been met. However, John, his wife, and the other child collectively must fulfill the remaining $2,000 in deductible before the coinsurance would apply. So it could be that John has an incident and he has $1,000 in costs subject to the deductible. Now there's $1,000 remaining. Maybe his wife goes in. She's got $800 in costs, right? That's going to still be applied, and there's $200 remaining in the deductible. Then his other kid goes in and satisfies the remainder of the deductible. Now the whole family has been met. But that's the difference. That's the embedded structure. One person can't consume that whole family deductible or out-of-pocket maximum. So let's see what the difference in cost is when we go over to a non-embedded structure. So in this scenario, John's going to pay $4,800. He's got $4,000 for his deductible, another $800 in coinsurance, because now there's $4,000 that's subject to coinsurance. And now there's no deductible that applies for anyone the remainder of the year, because they've met it for the whole family. So again, the main difference in this is that there's an individual deductible for each person inside the family deductible, but once the family deductible has been reached, or out-of-pocket max, all the provisions apply for everybody, okay? Really is just trying to limit the financial exposure for a family, especially on some of these higher deductible plans, so that, if something really awful were to occur, they're not on the hook for the full family deductible on one person. Minimum essential coverage. So this is an ACA piece I just want to cover here. So there are MEC plans, minimum essential coverage plans. The ACA had what is known as an individual mandate. That individual mandate for coverage stated that you had to have a health plan that met minimum essential coverage requirements. And so there was 26 essential services that were defined in the law, that must be covered with no cost share for the employee as a result, or the member in that plan. So if you didn't have that, then there was a tax penalty. Congress removed the individual mandate in 2019, but before that was removed, one of the things that was born was the MEC plan, a minimum essential coverage plan, a very, very, very bare bones health insurance plan that covers those 26 essential coverages with no cost share, and then usually had a fixed indemnity component for things like hospital stay or other things like that, where, okay, you're in the hospital, we'll pay you a set number of dollars per day that you're in the hospital, and it's paid to the employee, right? Or it's paid to the hospital or the employee. It depends on how they've structured it. But it's not a true full health insurance plan. Now that that has gone away, a lot of people still believe that there's an individual mandate and a tax penalty in the law that does not exist. But MEC plans still remain popular in certain industries, particularly kind of large franchises or fast food, things like that, that have high turnover hospitality, where employees may just be looking for some first dollar coverage so they can get their physical every year, but know that they're not going to be paying for a full medical plan. These are kind of the categories of the minimum essential coverage requirements. Just in the interest of time, I'm going to move on. You can see these in on healthcare.gov. You can get access to that. Minimum value requirements, minimum value plans. So in addition to the MEC requirement, there's an additional requirement on employers when it comes to the coverage that is offered if you are subject to the law's regulations. The ACA's employer mandate only applies to groups that have on average 50 full-time equivalents over, I believe it's 10 months out of the year. There's a calculator that you can use to see, and then you're classified as an applicable large employer. If you have 50 or more full-time employees, you're automatically going to be in there. There's more of those that fall on the bubble that there's some tracking that comes into place. But if you're required under the ACA to provide qualified health insurance, there are affordability measures that have to go in place. The law, you cannot make an employee contribute more than 10% of their discretionary income as part of health insurance. The plan also has to be designed to cover at least 60% of the total cost of medical services for a standard population. In addition to that, benefits must include substantial coverage of physician and inpatient hospital services. So you might be asking, why is that split out separately? Because you can have some smaller plans that are designed where, at least in terms of the deductibles and copays, it would be covering 60% of the total cost, but they only have limited benefits for hospitalization or inpatient services. In those situations, there's an actual actuarial value that must be assessed and shows that it provides at least 60% of all assessed costs, and then that would mark it as qualified, meeting the minimum value requirements as well on the plan. There are some employers, this is common in larger franchises, where they'll kind of have the plans they want to offer, but then they'll also just have essentially an MVP or minimum value plan that's meeting the affordability thresholds and minimum value there. A lot of times these plans aren't well adopted. It's more focused on us because the other plans would be considered unaffordable for the other employees. And this is more just an option there. But a lot of times in those employers, you have large groups that, the population this would be more focused towards, maybe better would be qualifying for Medicaid or something else along those lines. But one of the things just to understand as well is that these requirements are very important, because if you are an applicable large employer and your employee goes out onto the health insurance marketplace and enrolls in coverage and gets tax subsidies on it, you're going to get assessed a tax penalty unless you can prove that you offered that individual qualified health insurance, and then the employee is going to have to pay back the federal government the subsidies that they received, right? So that's where all of this comes into play. So coordination of benefits, that we're getting here towards the tail end, and we'll kind of get out for Q&A. when employees or members have more than one health insurance, there are rules for how benefits are coordinated. These rules are not set by a government entity. They're set by NIAC, the National Association of Insurance Carriers, but all member carriers have adopted them. So they're pretty much universal. So the first is a non-dependent dependent rule. This is pretty straightforward. The plan that covers the member as the subscriber is always the primary payer. They're always going to cover it first. So if I have health insurance and my spouse has health insurance, my spouse's plan is secondary because I'm covered as the subscriber on my plan. The active versus the inactive rule. If someone is covered as an individual on a plan that's an active employee versus the dependent somebody who is on a retiree or layoff plan, right, or COBRA, right? The plan that is covering the subscriber as an active employee versus a COBRA or retiree participant is going to pay first. The birthday rule. So this one's always the most fun, I would say, in my opinion, because I didn't realize it until I got into benefits, but basically, and this applies to kids, because this is a common question when we're working with employees and their kids coverage. If somebody has a kid that's covered on the plan, and the question, and they also have coverage from another parent, the question is which plan pays primary? The answer is whichever parent's birthday falls first in the calendar year. It's not which parent is older. You could have somebody who is, spouses that are 5 years apart, and the older spouse, let's say their birthday falls in November, and the younger spouse, their birthday falls in March. The younger spouse is going to pay primary on the kids because March happens before November in the calendar year. That's how that coordinates. Medicare has its own set of rules. So by law, Medicare is the payer of last resort, except in rare circumstances. So what this means is that any other insurance is going to pay before Medicare. As a taxpayer-funded plan, federal government's requiring that the private insurance pays before Medicare does. If somebody is enrolled in Medicare and their employer-sponsored health plan, the health plan will pay first unless the employer has fewer than 20 employees. Cost sharing with secondary coverage. So important things to understand is that members are still responsible for any deductible on both their primary and secondary insurance before the plan will pay any benefits. This is really important when you're dealing with high deductible health coverage, because if somebody enrolls in a high deductible health plan and their spouse covers them on their plan, which is not HSA compatible, not an HDHP, they cannot contribute to an HSA in order to help cover that cost. And now they have to satisfy and pay their full deductible before their secondary insurance can kick in, even if their secondary insurance has a lower deductible, because the member agreed to that cost exposure and will have to satisfy that deductible before the secondary plan is going to pay anything. So it's very important that those who enroll in high deductible health plans are not covered on a secondary plan that's going to pay first dollar coverage, because it really defeats the purpose of that HSA pairing. After both deductibles have been satisfied, secondary insurance will be billed for anything that hasn't been paid. It may result in no cost for the insured overall, but really the coordination of benefits occurs so that providers aren't over reimbursed for care. And there was the last bullet point. So ultimately, what does this mean for employees? Health insurance is not as simple as it once was, and the confusion is seen in employees as they're working through this. 74% of employees say that at least some things they don't understand about their health insurance, whether it's deductibles, copays, finding providers in network. 48% would prefer to speak to someone either in person or over the phone to talk about it because they don't fully understand it. And the last statistic here to me is the most concerning. 27% of Americans have admitted they've avoided going to the doctor even though they had health insurance because they didn't know what was covered and they didn't want to risk having that cost, right? So that's where education becomes so important, both for employers and employees. So what does this mean for employers, right? There's different methods that you can take to help address these different concerns. But primarily, there's three different options here. HR can take on the role of educating employees, which is more accessible and easier to do in smaller populations. Employers can outsource education to a benefits broker, an enrollment firm, or they can also contract and have people do one-on-one counseling to better help them understand their benefits. Before I open this up for Q&A, I just want to take one quick moment and bring up a benefits program that's HR Simple is sponsoring. So understanding how confusing this all is, right? And the barriers that exist for many employers in being able to offer good quality health insurance that attracts and retains employees, especially when you're in a smaller market segment, if you will. What HR Simple has done is partnering with the Health Benefit Alliance is put together a benefit offering that really is one simple streamlined solution from health insurance through your ancillary dental, vision, life and disability, and voluntary benefit options as well, right? There are 4 different plan designs, plan options that are part of this that are available and offered. All of these plans do satisfy the ACA requirements around minimum value and the minimum essential coverage, right? So it's ACA compliant coverage and plans that are available there. And these are paired as well with voluntary offerings that are designed to help employees with some of that cost sharing as a result of that come throughout their overall open enrollment. The other thing that I will just note about this as well is that in terms of the process here, right? EP6, my company, we're involved in helping alignment for implementation, understanding the overview, providing enrollment support with a benefit counselor, an app to help with the communication, as well as platform to assist with managing eligibility so that you're not dealing with manually adding terms or new hires or so on and so forth with the carrier. So with that, I'm going to open up the floor for questions and turn it back over here to Amy.
Thank you, Kyle. That was a lot. I am definitely open to doing another follow-up one of these just to kind of like dig in a little bit more where maybe you weren't able to get to. So we can definitely talk about that. And also if you guys want to hear more or any other topics that you have in mind that you want to see covered, just email them to me. I'm definitely open for that feedback. So we have one question in the Q&A box that I'm going to get to first, and then I have a couple that were emailed to me that we'll go through if we have time here. So this is a long one, but it says, we are an agency with 245 employees, and we recently switched to an HMO plan from an EPO. Our executive team is considering offering our employees 2 medical plans. This would allow staff to choose between the plans so they may pay less in premiums and have more take-home pay. However, I argue that if you have to utilize the coverage, they will have to pay more out of pocket and having lower coverage. Looks like they're asking, would you recommend a company to offer 2 medical plans?
So this is a great question, and I think there's a number of different strategies you can employ here, right? So I think I don't know the specifics of your plan design, so I don't want to comment necessarily about the overall cost that's in place with employees, but there are ways to save in premium that doesn't necessarily mean that they're going to have a higher out of pocket. Now, most of the time they will, as you've correctly noted here, right? Most of the time people are going to, in exchange for a lower premium, there's a higher out of pocket cost share that's involved. What I would say is, you can look at those plan designs in an HMO where it is pretty robust. However, the trade-off to that is it's limited just to those providers, right? So offering 2 plans is a common strategy, and I think is helpful when employees are provided choice. But it is important to be intentional about your delivery strategy and education on that, especially if you're offering something like one that's a high deductible health plan where they can contribute to an HSA and cover some of that with voluntary coverage versus a lower deductible, more typical copay structure, right? And one of the things I forgot to mention is that the HR Simple plans are built on copays versus deductibles, right? Where people are, deductibles often scare people and create barriers to care. But I think to your question of when do you recommend offering to health plans, I've seen employers go this route where there was a network change and they want to make sure and it's a pretty large disruption. So they offer two health plans, one that allows employees to keep access to their current providers and other employees to switch if they're looking for cost savings or aren't married to a provider. Others will do it, just based on providing employees different choices. But I would say it doesn't necessarily mean that they're going to have to pay more to utilize that coverage. It just depends on how the plan is structured. I hope that answered the question. But I'm happy to deal with more in follow-up.
Okay. Yeah, that was a really good question. It seems like it would be kind of the natural solution if you have a really broad range of ages in your workforce. Like you have people just coming out of college.
I'm glad you brought this up because, people, so high deductible health plans can be a really cost-effective, good solution for employees if they understand the full implications of how to utilize that plan, right? Young, healthy populations do really well with level funded plans and high deductible health plans because they don't see the doctor all that often, right? They're young and healthy. And what they can do is they can sock away money into an HSA that would be premium going to a health insurance company that just stays with the health insurance company. That HSA continues with them year over year. And when they turn 65, they can spend it on anything without tax penalty. It turns into an IRA, essentially. So Linda, you've got a great question here. Would you suggest employers contribute to HSAs to encourage employees to utilize that type of plan? That can be a very effective financial strategy. And a lot of times, if you run the numbers, you'll find that even with the HSA contribution, you're still paying less than you would if they enrolled in the full, fully insured copay plan, right? But the key thing there in encouraging employees to utilize that really comes down to education, helping them understand that preventative care is still fully covered, that HSA isn't front loaded like an FSA, right? It's based on when money is deposited. So they want to make sure they're utilizing that correctly, that they also understand some of the other pieces, because there are folks who have chronic conditions who may be really drawn to the low premium of a high deductible health plan, but they're going to set themselves up for a lot of financial hurt early on in their plan because they front loaded their exposure, right? So making sure that they understand, because there's a lot of times as well where actually the high deductible health plan is a better overall financial scenario, because if they're max out of pocket and the total premium that they pay is less on the high deductible health plan, then if they're hitting their max out of pocket on the copay plan, right, they've already paid all that premium, plus they've hit the max out of pocket. I wish I had a financial illustration I could show you right now. It's easier to see, but essentially, yes, HSA contributions is a great way to incentivize employees to utilize the plan, but you want to make sure you've got a good education infrastructure, because that's ultimately going to be what gets them going. Yeah.
Yeah, very good question. I think she has a follow-up. It says, plus the tax advantages of an HSA. Education is key and very difficult in our particular industry and age demographic.
Yes.
That's a great point. It seems like you could just have a full-time employee doing all of this and have enough work for them. Yes. Probably throughout the year. Are you seeing trends like, are more companies providing, geez, that's me. Are you seeing more companies providing HMOs versus PPOs? Like, do you have any information about, one versus the other, or how many people are doing what right now?
That's a good question. So I would say HMOs in a large part have kind of leveled off. Had been really popular for a while. As more plan options have come out, EPOs became more popular as a way to get to that because it's less restrictive in the network compared to an HMO, right? Point of service plans as well, because still some cost savings, but out of network coverage. I don't have any data off the top of my head that I can reference on where that trend lies. But what I can tell you is that self-funded plans is a growing emerging trend because of the cost savings that are in place. The biggest barrier to self-funded plans is administrative hassle or education for the employer in understanding how all that works and how those cost savings can come into play. But then in addition to that as well, right, education for the employee and navigating that new self-funded health plan.
Very good. Thank you for that. I have one question about your specific benefits program. It says, what if I have employees in multiple states?
Sure. So the way that insurance is regulated in the US is a little bit odd, but it's by state, right? So there's no like federal department of insurance that's involved. So for the insurance contract is it's the state where the business is located. That's the site of state. That's where it's regulated. And then employees in other states can participate in that plan without restriction. It doesn't have issue. It's just where the plan is regulated is going to be the site of state where the business entity itself is located. So there's no barrier to somebody. So you have an employer that's based in California and they have employees that live in Arizona. That Arizona employee can participate in the California-based employer's plan. The thing you just want to make sure to understand is what does network coverage or things like that look like for people in other states.
Okay, awesome. Somebody just asked if we want more information regarding the benefit plan through HR Simple, who can we reach out to? That's a great question. I just put some information in the chat below. I will send out everything you guys need to know. I will send out a link so you can book time with a consultant if you'd like, or if you just want more information, there will be a website too. So I'll put that in there. Your SHRM and HRCI credits are in the chat. They'll also be in the follow-up email that I'll send later this week. And like I said earlier, if you guys have any suggestions on topics you want to see us cover, if you want more information about this, if you want to see Kyle come back, just email me. I'm open to all of that feedback. And just thank you so much, Kyle, for all of this. It was such a good presentation. I don't know how you got that much information all in that time frame, but we really appreciate you coming on and sharing your expertise with us.
My pleasure. Thanks for the opportunity.
All right, everybody, have a great day. We'll see you next time.
Take care.